Bismillahirrahmanirrahim. Well, today's presentation is about non-muscle invasive bladder tumor. To start with the presentation, let's have a scenario first. A 55-year-old gentleman came to urology clinic with complaints of hematuria for past 2 weeks. On inquiring the details, he said the hematuria was total, it was painless, and throughout the urination continues. He had lower urinary tract symptoms for past 6 months, more of storage alerts, including frequency, urgency, and urturia. Otherwise, he got no associated symptoms, the systemic review, other than generalized body ache and fatigue. On asking about the personal history, there was complete pack year of smoking for 20 years. What comes into your mind? Let more questions to be asked and differential diagnosis.
Bladder.
Okay.
Malignancy could be a possible cause because of this
Pack year.
smoking.
Okay, the outline for today's presentation is we'll talk about epidemiology, the risk factors, staging and grading, both the definitions of NMIBT and CIS, carcinoma in situ, diagnosis and the few markers, and detail about the endoscopic resection with histopath report, and we'll discuss about the predicting the recurrence and progression plus adjuvant treatment. Bladder cancer is the 10th most common form of cancer worldwide, with an estimated 549,000 new cases and 200,000 deaths. Bladder cancer is more common in men than women, with a respective incidence and mortality rate of 9.6 and 3.2 per 100,000 in men, about 4 times those of women globally. Thus, the disease ranks higher among men, in whom it is the 6th most common cancer and 9th leading cause of cancer deaths. Incidence rate in both sexes are highest in Southern Europe, including Greece, with the highest incidence rate in men globally. Western Europe, Northern America, although the highest rates are estimated in Lebanon among women. Other than certain occupational exposures to the chemical and water contaminants, cigarette smoking is the main risk factor for bladder cancer. And with the attributable risk, at least in United States, has reached that among men, with 50% of bladder cancer cases attributable to smoking in both sexes. Well, all these are the risk factors: smoking, personal or family history with a little impact, previous cancer treatment, chronic bladder problems, especially the chronic long-term UTIs, schistosomiasis, chemotherapy and radiation therapy, gender, obviously the male gender, exposure to certain chemicals, bladder, birth defect, congenitally, extrophy bladder, races and ethnicity, increasing age, smoking. All these are the risk factors for bladder cancer. Few facts from the recent European guidelines 2022: smoking stopped for 1 to 3 years, 2 to 2%, 2.4% relative risk of decrease for bladder cancer formation. If a person smoking stopped for 15 years, there is 1.1% relative risk of bladder cancer formation. Family history is obviously a little impact. Second degree relatives got twofold rise of bladder cancer with the 95% confidence interval. Citrus fruit seems to be decreased the bladder cancer. Recently, protective impact of flavonoids, Mediterranean diet like high consumption of veggies, olive oil, protein was linked to reduce in bladder cancer. Schistosomiasis, chronic endemic cystitis. So schistosomia, which results in bladder cancer. We all know the TNM classification. Today's topic is non-muscle invasive. We'll stick to the non-muscle invasive. TA, non-invasive papillary carcinoma. TIS is carcinoma situ, also known as flat tumor. Tumor T1 is the invade lamina propria subepithelial connective tissue, and T2 includes the muscularis propria. TA to T1, all these three comes in non-muscle invasive bladder tumor. We'll stick to non-muscle bladder tumors for today's presentation. Normally superficial, most common are superficial cancers, non-muscle invasive 70%, then locally invasive, muscle invasive 25%, metastatic is only 5%. Here is the bladder anatomy, contains of three distinct histological layers: urothelium, lamina propria, detrusor. This is the grading system since 1973, then recently 2004 WHO grading system. Grade 1, grade 2 and grade 3. Grade 1 is differentiated, grade 2 is moderately, and grade 3 is poorly differentiated. Pun lump, low grade comes in grade 1 and high grade also comes in grade 2. Pun lump is primary urothelial neoplasm of low malignant potential. This is the grading of urothelial cancer. CIS, carcinoma in situ, multifocal, can occur in upper urinary tract. 54% progress to muscle invasive disease. Response to intravesical treatment with BCG or chemotherapy is an important prognostic factor. How we define is primary, secondary and concurrent. Primary carcinoma in situ is those isolated CIS with no previous or concurrent exophatic tumor. It's called primary. Secondary is CIS detected during the follow-up of patient with previous tumor. If a patient is having non-muscle invasive tumor or muscle invasive tumor, with the regular cystoscopy follow-up checkup came to be CIS, called secondary. CIS with presence of exophatic tumors also carries worse prognosis, known as concurrent. If we talk about the diagnosis of the bladder tumor, the chief is to take the history about the hematuria status of the patient in detail, like duration of the hematuria, onset of the hematuria, then is it painless or painful, is it intermittent or continuous, either with clots or without clots. We'll also ask about the transfusions or trauma, is it initial, gross or terminal. Then associated, like is he taking antiplatelets, blood thinners, bleeding diastasis, details of smoking history, and occupation carry very important role, as already told. If a person is in industry, rubber industry, carries the risk factor for having bladder tumor. Then history of trauma or transfusion as well. And detailed general physical examination with systemic review, including lower urinary tract symptoms according to the International Prostate Scoring System IPSS. Then investigation, we'll talk about the chief and diagnostic investigations, which carries both sensitivity and specificity. Number one is urine cytology, then urinary markers, molecular level markers, ultrasound, the first initial investigation to be carried out, followed by contrast enhanced CT KUB and kidney urine bladder plus chest abdomen pelvis for metastatic workup. A little bit talk about either we should go for CT or MRI with contrast, and the role of PSA is 10% of the bladder tumor, which carries risk factor for having prostate cancer too. So PSA is also an important modality to be done. Clinical presentation, hematuria, 80% of transitional cell carcinomas, gross is in 85%, microscopic in all patients. Degree of hematuria is independent of disease grade and stage. It's very important to know. Often asymptomatic. Bladder irritability symptoms most common with CIS, frequency, urgency, and dysurias. Imaging, intravenous urography to recommended in upper tract, also in lower tract as well, to see the filling defects, renal, pelvis, ureter, and hydronephrosis. CT scans for muscle invasive tumors, then ultrasound. Urine cytology is a standard non-invasive tumor-specific marker test. It's always done adjunct to cystoscopy, major role in detecting the high-grade tumors, detect carcinoma in situ, defined criteria for malignancies, malignant cells. All these come in the characteristics of urine cytology. Then markers. All these markers are performed as a tool for screening or adjunct to cystoscopy once the tumor is established. Nowadays, NMP22 is being done in different institutes. It is generally accepted that none of the currently available tests can replace cystoscopy. The important thing to know is, however, urine cytology and biomarkers can be used as adjunct to cystoscopy to detect the invasive tumors, especially the CIS, carcinoma in situ. Here are the few snaps of a bladder tumor. You can see the hyperechoic area filled is urine, and there is a hypoechoic mass at the left lateral wall, posterior wall. It's a papillary. In second picture, there is a huge tumor arising from the dome, right lateral anterior wall and dome of the bladder. These are the ultrasonic demonstration of bladder tumor. And you can see the contrast enhanced CT of the bladder. There is a contrast uptake of the tumor at left lateral wall. In second picture, right lateral wall. Imaging CT is an unreliable for staging tumor confined to bladder tumor. CT is accurate for staging advanced diseases. The important thing to know is MRI is superior to CT for staging early tumors. Contrast enhanced MR is probably superior to unenhanced MR for staging bladder tumors. CT and MR both have important limitation leading to overstaging and understaging. So CT and MR are equal in their ability to detect lymph node involvement. Lymph node involvement, especially muscle invasive tumor for true pelvis lymph nodes. And CT and MR may be useful for monitoring purpose. Like if a patient is having muscle invasive bladder tumor, once he has been given radical curative treatment, then on follow-up we can ask patient for CT and MR for monitoring as well. CT and MR are variable for detection of recurrence, again used in follow-up. Here is the MR picture of pelvis. You can see multiple tumors arising from the right, left and dome of the bladder. In second picture, again there are two in number. So nothing can replace cystoscopy. If a patient came to you with hematuria, as the scenario has been described in very start, so cystoscopy is gold standard. Complete visualization of urethral and bladder mucosa, allow biopsy and resection, both therapeutic and diagnostic. Obviously, it's an invasive procedure. We need to get it done through GA or spinal anesthesia. Can be performed with minimal discomfort with topical anesthesia and urethra if we have a facility of flexible cystoscope. It's expensive. Sensitivity is 73 and specificity is 68.5%. The newer modality which is used nowadays in tertiary care setups can be, this sensitivity is enhanced by to 97% with ALA induced fluorescent but not widely practiced. Aminolevulinic acid is also known as fluorescent cystoscopy. We'll show the pictures later on. Endoscopic assessment at initial diagnostic cystoscopy, it is necessary to document the following. So very important is these findings of the operator surgeon. It's very important to stage the disease. The tumor size, number, position, growth pattern, either is papillary, solid, sessile. Mucosa is normal, red area of red, irregular mucosa. Lower tract, we have to comment about the urethra, prostatic urethra as well. The role of bimanual palpation, is there mass before resection or is there mass after resection? Both carries very important significance, especially in muscle invasive bladder tumor, size of mass and mobility as well. Here are the few examples of cystoscopic images. You can see the papillary growth with a diverticulum in first picture, followed by second huge papillary growth. All these cystoscopic views of bladder tumors. Here is the carcinoma situ, is a flat tumor including the whole of the dome of the bladder. We'll talk about fluorescent cystoscopy, is used with 5-ALA. A precursor to heme biosynthesis is instilled into the bladder, which is taken up by neoplasm. Blue light excites the agent and can detect otherwise unseen CIS on white light. Additional detection rate is 20% for all tumor, 23% for CIS, huge percentage for CIS, and 9% for reduction in risk of recurrence at 9th month. Can also give false positive due to inflammatory. It's a drawback for fluorescent cystoscopy. It's a pictorial for fluorescent cystoscopy. You can see with the plain light in first picture, white light, and with the addition of 5-ALA, the CIS is appreciated like this. Second picture. Again, you can see with light, white light, we mostly appreciate as hyperemic area with a new vascularization as well. But with seen through the fluorescent cystoscopy, you can appreciate a reddish area at the dome of the bladder. So after the investigations, history examination plus investigations, we'll talk about treatment options for superficial bladder cancer. These are the previously performed newer techniques, newer treatment options we can offer to the patient, but remains the gold standard is transurethral resection of bladder tumor. Laser treatments are also done, not in Pakistan, like we use diode laser, cadmium laser, KTP light lasers, photodynamic therapies, intravesical therapies can be given as adjunct to the transurethral resections. In intravesical, we have options of chemotherapy, mitomycin C, epirubicin, gemcitabine, then role of BCG, very important, interferon, BCG plus interferon, and role of cystectomy. In 1970s and 80s, role of cystectomy was done in non-muscle invasive tumor, but the invention of BCG in later in 90s, so the role of cystectomy has been obsolete now. So transurethral resection of bladder tumor is done in regional or general anesthesia. Spinal is an initial treatment for visible lesions and is performed to remove all visible tumor and provide specimen for pathologic examination to accurately determine stage and grade. Before TURBT, already told all these to be done. Avoid over distension. 50 to 70% prevent, perform and improve visibility of CIS. While doing TURBT, we don't need to over distend the bladder. Once the bladder is over distended, the detrusor muscle is stretched and mucosa also stretched. So the CIS type tumors are invisible during white light as well, or during the procedure. Bimanual examination under GA, under spinal anesthesia, before panting and drabbing, we have to do the bimanual palpation. Should be done before and after resection. Fixation or persistence of palpable mass after resection suggests locally advanced disease. Not necessarily. If the tumor is clearly small or non-invasive, then not repeated. Surgical principle: flexible cystoscope are preferably the 70-degree rigid rod lens, which allows maintenance of the anatomic relationships. Low-grade tumor can often be removed without the use of electrical energy. The concept behind this is to provide the histopath. Once we have to like cut or coagulate, the tissue for the specimen is damaged. So without energy can also be removed. Lifting the tumor edges away from the detrusor lessen the chance of perforation. Like once the detrusor has been cut deeply, then we have left with the serosa, so there is a chance of perforation as well. After all visible tumors has been resected, an additional pass of cutting loop or a cold cup biopsy can be obtained to send the pathologist separately to determine the presence of muscle invasion of the tumor base. Once the you done with the cystoscopy and you have done with the resection of the tumor, then it's better to take a separate specimen from the detrusor just to see the invasion of the tumor, either muscle is involved or not. Pathologists should comment on the size, the tumor grade according to the WHO criteria. It's a PUNLEP or grade 1 or grade 2, T1 or T2. Depth of tumor invasion, either is invading the detrusor or not. Then the presence of CIS, whether his muscle is present in the specimen or not. It's very important in first resection. Specify the presence of lymphovascular invasion, is an unusual variant and carries the worst prognosis. If there is uncertainty over the pathology, a further early resection should be done within 6 weeks. It's recommended with. So endoscopic, once the TURBT has been done, so a little bit talk about the complications. Obturator reflex perforation is the obturator nerve bilaterally goes through the lateral walls of the bladder. Then obviously bleeding, TUR syndrome, less likely in the bladder tumor, it's most common in TUR syndrome, TURP. Use obstruction, it's very important. If the tumor is present on the right lateral walls or near to the ureteric orifices, so better is to do the cutting rather coagulation. Once you have to coagulate, then the ureteric orifices are obstructed or narrowed down. Unrecognized disease, perforation, extraperitoneal or intraperitoneal. Okay, this procedure I think is chalegi ki nahi to. नहीं चल रही. It's a cystoscopy plus the TURBT of procedure which was performed a few days later in hospital. Is a urethra, you can see. ऐसा नहीं है ना, नहीं चल रही. Last time भी ऐसे ही हुआ था मेरे ख्याल से. हाँ हाँ जी वीडियो. हाँ, so you can see the urethra. There is the external sphincter. And the cystoscopy, you see the huge it's a sessile, huge bladder tumor on the right lateral wall. It is the tumor. More than 10 centimeter was the dimension, and it's totally sessile and a little bit component of papillary. After resection, the view, here you can see the resected area, including the right lateral wall, anterior wall. Is a bladder neck. You can see the right ureteric orifice over here. It's a right ureteric orifice, and there's a more distended type bladder. So left ureteric orifice is, I will show again. landmark is bladder neck. We used to come, yeah, there is a left ureteric orifice. So you can see the aerial view. This is the aerial view of resected area. It's a complete TURBT, you can say. Detrusor fibers are also seen over there. It comprises of right lateral, anterior and dome as well. So why second look TURBT is very important? There are few indications for second look TURBT. Like residual disease after initial TURBT, it's an indication. When specimen contains no muscle, like you have done with the first resection, then histopath comes to be there is no muscle in the specimen, so we again go and do the TURBT. If histopath turns out to be high grade or T1, either muscle is seen, whatever the situation is. If it turns out to be a T1 tumor, then again you have to go for second look TURBT. These are the chief indications for second look TURBT. Timing is most common recommended within 6 weeks after initial TUR. Should include complete resection with primary tumor site. These are the evidence. Half will have residual disease on second look. Why its TURBT is important? Then understage is more likely if muscle is absent, 50% versus 15%. 1/4 will have upstage after TUR, second TUR. 1/3 will have to change management of the tumor. Then 20% increase 5-year disease-free survival in patient with complete TURBT. So what next? Like we have started from history, examination, then investigations, followed by a cystoscopy resection. We'll talk about the second resection as well. So histopath came in front of you. If it turns out to be non-muscle invasive tumor, we are talking about non-muscle invasive tumor. So this is the main important table for today's presentation. Is either tumor fall in low risk, then what is the definition? Primary, the tumor should be primary, it should be solitary, with both primary and solitary and less than 3 centimeter, no CIS. All these 3-4 findings are from cystoscopy. Then it's TA, non-papillary tumor, non-invasive tumor, low grade / grade 1. When all these 5 characteristics are present, we say it's a low risk tumor. What next for such type of characteristics of definition of tumor? The treatment is only one single instillation of chemotherapy followed by a TURBT. That is mitomycin chemotherapy. Mitomycin is widely available, or gemcitabine, or if both these are not available, then we can offer also BCG. Single instillation within 24 hours, subjective to the hematuria. The instillation also carries few indications for the patient. Then follow for 3 months. Otherwise, the treatment is sufficient for low risk tumor. We'll talk about high risk. In high risk, any of the following is present, then we call tumor is high risk. Either it's a T1 tumor, histopath says. Is it high grade or grade 3 tumor? Again histopath. There is a presence of CIS, again histopath. The cystoscopic finding is multiple and recurrent and large, greater than 3 centimeter. Either it's a TA, grade 1, grade 2 tumor. All these conditions must be present. Then it's known to be a high risk tumor. High risk tumor, non-muscle invasive, carries intravesical full dose instillation for 1 to 3 years, or patient can be offered radical cystoprostatectomy with ileal conduit in highest risk tumors, that is subgroup. So what's the protocol for installation of BCG? It's a huge protocol. In today's presentation only talk about the surgical. We'll talk verbally like intravesical BCG. After first resection, we have to do the second resection within the 6 weeks, then followed by induction BCG and maintenance BCG. Induction BCG is we have to instill BCG per week for 7 weeks, then after 3 months, 6 months, 12 months, 18 months, 24, 30 and 36 months. In between all these months, we have to perform cystoscopies, follow-up cystoscopies for a period of 3 months. Once the BCG has been given within 3 years, this patient should be followed for a period of 10 years with 3 monthly cystoscopies. Subgroup of highest risk tumors, all these are the characteristics: T1 grade 3 associated with concurrent bladder CIS, multiple or large T1 grade 3, any of these with also BCG failure. BCG failure patients are those who are not responding in high risk patient. So all these offered radical cystectomy should be considered in those who refuse radical intravesical full dose instillation. So this table is very important. Told about the risk stratification, including the treatment with definitions and their follow-up. Once the disease is established, this is the EORTC table, which calculates the prediction of recurrence and progression of disease. So thank you for today's, as I have covered only the surgical